Yes, so I just a brief on our data and where we are at. So currently we have about 1.377 million persons of all ages living with HIV, and this is from the Kenya estimates of 2023. Amongst this population, we have about 1.3 million that are of the adult age, that is the age of 15 years and above. And we have about 67,869 children of the age of between 0 and 14 years, forming part of the persons living with HIV. So we have made quite some significant steps and progress in terms of the HIV epidemic control, especially among the adult population. But when we look at the UNAIDS standards for HIV epidemic control, where we use the 95-95-95 cascade or targets, where the first 95 is people getting to know their HIV status, so meaning that we are able to identify 95% of the people with HIV are being diagnosed, and out of those 95% to be on treatment, and out of the population that is on treatment to have 95% of that population being virally suppressed. So when we look at our performance using the 95-95-95 target or cascade, this is where we are at, and this is illustrated in the diagram on the right. So we see that when we look at all the population, our performance is at 94, 94, 89. When we move to the right of the graph, we have the adult population performance at 95, 95, 90. But when we look at the middle three bars, which represent the children, we can see how our performance is. We are at 85% of identifying children with HIV, 85% of those that have been identified being on ART, and 74% of those that are on ART being virally suppressed. So this is clearly showing us how our children are lagging behind, and we really need to do something differently so that we are able to, bring the children performance on board, so that we don't keep losing our children to HIV and AIDS complications. So when we look at our progress as of the year 2022, we have about, as I've already mentioned, approximately 68,000 children that are living with HIV. And from this population, we are having 6 children dying daily due to HIV/AIDS related complications. And when we look at the new infections of children, we are seeing that we are getting 12 children being newly infected with HIV every day. Now, out of this population of the new infections amongst children of 0 to 14 years, we see that 67%, which represent 2,989 of all new infections in children, that is the age of 0 to 14 years, being attributed to either pregnant and breastfeeding women not receiving ART, that forms 35%, or this population having their treatment interrupted, and that is 32%. So you can see that we really we are getting a bigger percentage of the new infections coming from mother-to-child transmission. And that's why we are focusing, or the focus of ending AIDS in children is on prevention or elimination of mother-to-child transmission. Because if we deal with this population or the new infections, then we are going to have a very diminished number of children getting or get new infections from HIV. Now, the optimal regimen for children for ART is the DTG regimen. So when we look at the population of children that are already infected with HIV, those that are on treatment, that is represented by the graph in the middle. We are seeing that not all our children have been optimized on care. That means not all of them are on DTG, and we have tried to represent this across the 47 counties. So the counties with a darker shade of maroon represent counties where we have less than 20% of children being optimized on care, and the areas where we have a lighter shade being the counties where we are doing fairly well in terms of optimizing children on care. So we can see from this map, to mention the northeastern counties where we are having the darker shade of maroon, showing that we still have quite some work to do in terms of optimizing our children, but also to mention Homa Bay, Kisii, Makueni, that are doing fairly well based on this presentation of our data. When we look at the mother-to-child transmission rate, Nationally, we are at 8.6%. Our target is to get to less than 5% for us to be able to acquire validation of elimination of mother-to-child transmission. And when we look at the MTCT rate across the 47 counties, the representation is as represented on the map. So the darker shade again, where we have higher MTCT rates, and the lighter shades where we have lower MTCT rates. So to mention here is that you can see counties like Marsabit, Tana River, Lamu, Kilifi, Taita Taveta, Kwale, Mombasa, having lower MTCT rates. But this is when we look at data again, these are the counties that have got the highest burden of missed opportunities in terms of maternal testing at ANC. So you can see that the identification of the mothers in these counties is fairly low, but their mother-to-child transmission rate is quite high. Yes, so we continue looking at our current data. So this is the main indicators that we are interested in prevention of mother-to-child transmission, for us to say that we are ending AIDS in children. So when we look at maternal ART, we are currently at 86%, and our goal is to have all mothers that have been identified to be HIV positive being put on ART. For infant prophylaxis, we are currently performing at 75%, yet our goal is to have all children that are exposed to be on infant prophylaxis. For viral suppression amongst pregnant and breastfeeding women, we are currently at 96%, and still our goal is to have all mothers being virally suppressed. Our MTCT rate, as I've already mentioned earlier, is at 8.6%. Our goal is to get to less than 5%. For the children and adolescents living with HIV that are on ART, we are currently at 87.4%. Our target is to get to more than 95%. And for the HIV ART optimization, we are currently at 92%, and the goal is to have all children being optimized on DTG regimen. Now we get into the Global Alliance to End AIDS in Children. So Kenya is among the first countries to shape the Global Alliance to End AIDS in Children by 2030, which is an initiative of UNAIDS and WHO and the UN agencies. And this entails elimination of mother-to-child transmission of HIV, and also putting children on optimal care and treatment, those that have been identified to be HIV positive. And our president has rallied himself behind this commitment to end AIDS in children by 2027. So it means that we are 3 years earlier than the Global Alliance target of 2030. And our CS Health made a commitment in Dar es Salaam on the 1st of February to fast track, continually examining the glaring gaps that we have, and also fast track ending AIDS in children. And that's why we are all marshalling ourselves behind this commitment that was made by our CS Health on behalf of the nation. So when we look at where we are at, for us to be able to end AIDS in children, number one is first of all to look at our missed opportunities and mop them up, but also strengthen our systems and our mechanisms of reporting, our mechanisms of data collection and service delivery, so that now we can be able to say we are on track in terms of ending AIDS in children. So this is where we have started from, looking at our missed opportunities. So we reviewed our data of between February 2022 and March 2023, and this period was picked because it is post-COVID, and also at least at this time, we had started receiving the basic commodities that we need in PMTCT. So we said, let's review this data and see what missed opportunities there are, so that we can, first of all, start from mopping them up as a jump starter to this journey of ending AIDS in children. So when we look at the missed opportunities in the period that we have mentioned, we look at the missed opportunities in HIV testing at ANC. We find that we have 345,630 women that missed testing at ANC, and out of those, we have those that were not started on ART yet. They were identified to be HIV positive, having missed opportunities of 4,180. Infants who missed prophylaxis were 5,697, and the CALHIV DTG first line missed opportunities, we are at 2,499. When we look at the different gaps in terms of viral load uptake among the CALHIV on ART, our performance is at 79%, meaning that we have a gap of 11% that translates to 12,650 in absolute numbers. Viral suppression amongst PMTCT mothers that are on ART, our performance is at 96%, meaning that we have a 4% gap, which translates to 1,910. And then viral load suppression among the CALHIV on ART, we are currently at 89%, giving us a gap of 11% that translates to 6,626 in absolute numbers. When we look at our implementation plan, so the Kenyan Plan to End AIDS in Children is a document that was developed with contribution from several key stakeholders, and these are the objectives of the plan. Number one is to reduce the rate of mother-to-child transmission of HIV, as I've already mentioned, from our current 8.6 to below 5%, that is by 2027. Number two, we want to increase and sustain treatment coverage among pregnant, breastfeeding women, children, and adolescents living with HIV to not less than 95% by the same period. All these targets are by 2027. Number three, we want to increase and sustain HIV viral load suppression among pregnant and breastfeeding women, children, and adolescents living with HIV to not less than 95%. We also want to reduce incidence of new HIV infection among adolescents and young people by 75%. Just here to mention that the largest number of contributors in new infections are the adolescents and young people. Then also we want to scale up prevention and management of TB, pneumonia, malnutrition, and other comorbidities that have been identified to be the leading causes of death in our CALHIV, and these are actually preventable causes, and also in adolescents and pregnant and breastfeeding women living with HIV by 50% by the same period of the year 2027. So we have 6 strategic interventions within the Kenyan Plan to End AIDS in Children. And the first one is to address vulnerabilities and inequalities that sustain the new infections and impede progress. So we are looking at the vulnerable groups, and we've already mentioned young and adolescent pregnant and breastfeeding women. We have mentioned the ASAL counties where currently we don't have any partner support, and we're also bringing on board any other group. So we are saying we are not leaving anyone behind in this strategic intervention. Number two, we want to address health system barriers to quality of health systems, and this includes barriers even at policy level, barriers at service delivery points, and all along the health system cascade. Number three, we want to address supply chain stability and sustainability. We know that we've had recurrent interruptions in our supply chain and also availability of commodities. So we are intentionally having an intervention where we will have supply chain stability and also sustainability. We are also addressing leadership and alignment of resources with country priorities. So we are bringing on board all the partners and key stakeholders in this journey, in this discussion, and in this agenda. Number five intervention is to build social capital and community intelligence to end AIDS. And last but not least, strategic intervention is to prioritize evidence-driven approaches and information systems, as Dr. Elvis already mentioned, as he was giving us his opening remarks. This is the timeline so among one of the activities in the plan is to have a rapid results initiative, which entails mopping up the missed opportunities, but also to strengthen the systems that we currently have in the PMTCT space, and also CALHIV care and treatment. So this is the implementation plan for the RRI. Most of our activities and planning started in the month of March and in February, and these activities we are seeing them or we are proposing or targeting that by the end of the month of December in 2023, we will have completed the RRI and we'll be able to document and show our performance or show our progress and our results as well. So we've had several activities that have gone before now, and that includes the virtual sensitization of key stakeholders, development of RRI tools and materials. We have a national level steering and technical committee that were appointed and are active and have been continually engaging. Front-loading of commodities in RRI facilities has already been done. And we also had a regional county planning meeting with the implementing partners and stakeholders in the month of May. And also we've had lab capacity optimization and sensitization being done. Currently, we are training healthcare workers from the 1688 facilities, and I will shortly explain to us how we arrived at the 1688, but also we've been able to train HTS providers in those same facilities and where and in the sub-counties where these facilities are situated. We just completed our stakeholder sensitization that was in the form of a mini stock taking meeting and officially launching of the RRI in last week in Homa Bay. And currently for the facilities where healthcare workers have already been trained, implementation has begun, and also community level interventions have also started and they are continuing. And these interventions includes CMEs, community dialogues, case file reviews, and also tracing of the missed opportunities. And this will span all the way into the month of December. During the same period between August and December, we will have, or November, we'll have monthly reviews being done, supervisions also ongoing on a regular basis until the end of the RRI period. In the month of December, when we conclude the RRI, we will have data being analyzed, and we will also write a report that we will finally submit in the month of December, and this will be culminated by a launch of the report, and also have an award giving ceremony for the counties that will have performed well, and also individuals and organizations as well in the different categories. So these RRI interventions are being focused in 1,688 facilities, although we've been saying, and we continue to say, that these interventions should reach all the facilities in the across the 47 counties. But because of time factor and resources, we had to limit ourselves to a specific number. And this is how we arrived at the 1688 facilities. We used weighted average to achieve at least 95% mop-up for the following indicators, that is maternal ART, infant prophylaxis, and maternal HIV testing. And then we purposefully included all the sites where we have children that have not been optimized on first-line DTG, and also went ahead to have at least 20 facilities in each of the ASAL and the semi-arid counties. And this gave us a total of 1,688 facilities across all the 47 counties. No, we went ahead and, developed or came up with thematic interventions, and we asked ourselves, what new thing can we do? Because we have been working and we have been, having a trend where we are going up, and then we do very well, reduce our mother-to-child transmission rate, and then we go down again, and our mother-to-child transmission rate increases. So we are saying, what can we do differently in the different thematic interventions so that we make headway, but also sustain our gains that we are going to make after the RRI period. So the thematic interventions, number one, is capacity building of healthcare workers, where we are having cascaded mentorship that is going to take three forms: one, roving; two, virtual; and three, site level cascaded mentorship. We are also going to have case file reviews for all missed opportunities, and viral load and early infant diagnosis gaps, including the non-suppression missed opportunities. And also we are training targeted healthcare workers, including the staff that work in MCH, and site level CMEs are also part of the intervention that we are doing in terms of capacity building. We also have expert webinars on thematic issues, and our first webinar is this one, and this will be running all the way into the month of October and November, where on a weekly or bi-weekly basis, we'll be having expert webinars in the area of PMTCT and CALHIV care and treatment, where healthcare workers can log in and just get to hear the different topics that are going to be discussed. We've also developed job aids that are new, and that includes client risk categorization and referral protocol, feedback forms for case reviews, and also a Kanban walkthrough pathway tool that we are going to to use going forward. For supply chain optimization, we have done front loading of the sites with commodities. We will have monthly commodity security meetings at both county and sub-county levels. We have a circular on the last mile commodity security optimization, but also we are shifting from lab to facility level early infant diagnosis and viral load collection of commodities. When it comes to data and data management, data reconstruction and management, we have longitudinal tracking for the PMTCT clients for all sites. And this is vis-a-vis what we are doing currently, where a mother is being followed separately from the infant, and we are seeing quite a number of missed opportunities, especially on the infant. Then we are going to optimize and scale up the PMTCT module use in the EMR. And we are also going to use what we are calling the Ushauri platform for us to be able to manage and monitor our data. And also the RRI tools that have been developed have been integrated into KHIS. So this becomes part of the routine data that we usually collect. When it comes to optimization of viral load and early infant diagnosis, we have sample transportation renetworking for the facilities. Testing labs have been optimized, and also we will have online results access for all the selected sites, and this will go a long way to reduce our turnaround time for the results. We have structural intervention for clients. So here we are saying that we have mothers or we have clients that are not able to be retained into care because of structural challenges. And so we need to link these clients formally to structural intervention partners with specific and also specific facilities. And we've gone ahead also to develop a referral and resolution linkage tool to the same structural interventions. In terms of advocacy, education, and demand creation, we have cascaded advocacy and demand creation. We have developed IEC materials that is both in soft and hard copies that is currently being disseminated, and also we are making use of social media to disseminate the IEC materials as well. We have a platform that we have called the Ask the Expert platform that is soon going to be activated, where members of the community, including healthcare workers, can log in and ask questions and get real-time answers. We also have linkage with community strategy and community-based organizations. We have not left the community behind. The community is very important for us to make any progress. And so they also have specific roles and areas of focus. Number one, in terms of capacity building, we are also doing trainings for targeted community champions, peers and mentor mothers, and we are not leaving behind our CHPs as well in this agenda. We will have regular webinars on thematic issues, as I've already mentioned, that will be targeting the community. Then we have capacity building of the health HCPs and the RRI TWGs on the need to listen, to be empathetic, and provide person-centered care. In supply chain optimization, we will have community-led monitoring that is going to be able to promote commodity and service security. So they'll be like, I don't know, policemen or reporters. When the community reports that we don't have commodities, then the facilities where these communities are linked to can quickly pick it up and cascade it upwards. Data reconstruction and management, we have longitudinal tracking for the PMTCT clients at community level, and this will be done by the expert mothers that are within the communities, but also the mentor mothers that are within the facilities, and this will promote enrollment into the and this will also promote enrollment into the Ushauri platform. And also at this level, there's going to be finding of the missed children and linking them to care, and this also includes the pregnant and breastfeeding mothers as well. When it comes to optimization of viral load and EID, we have treatment literacy and adherence counseling that is going to be done in the communities through the available networks, leveraging on lived experience to support adherence and retentions. We will also have referral for services ongoing, but also we are going to strengthen community to facility linkages for holistic care. When it comes to structural interventions, the community will be the ones on the forefront, especially through the community-based support groups for pregnant and breastfeeding mothers. Creating awareness on gender equity and human rights and GBV is what is going to be happening at the community level, but also stigma reduction and psychosocial support sessions will be ongoing. For advocacy, education, and demand creation, we'll have cascaded advocacy and demand creation, IEC materials being disseminated, and we'll also have Ask the Expert platform for the community as well. So that is the presentation that I had. The next are just photos of showing us where we have been and what we have done so far. So the top photo is our CS Health launching our Kenyan plan to end AIDS in children on Friday. In the middle section, we have Dr. Rose Wafula, head of NASCOP on the right, and Dr. Bashir Isaac on the left, our director family health, just giving us their opening remarks during the StockTech meeting and also the regional sensitization meetings. And the photo down there is the representation of the women living with HIV as they were doing their presentation and giving their remarks during the launch last week on Friday. And these are photos from the sensitization engagements that we have had so far with the different participants being in the different engagements. And we'd like to acknowledge Ministry of Health, NASCOP, and all our partners that are, I cannot mention each one of them, but they're represented in the banner projected. Thank you very much. I take it back to Dr. Caroline Mwangi.
Thank you, Dr. Nelly, for a wonderful presentation and, of course, giving us a snapshot of the current situation and the efforts at the ministry level through NASCOP to end AIDS in children. So I have been noting some questions from the chat. I can see some participants. If you'd like, yes. So maybe one question that has come up that I'd like to tackle. There are some I'll be tackling and there are some I'll be asking Dr. Nelly to tackle. So Dr. Nelly, maybe to start off with, the first one, and I think you had briefly alluded to it, what is there, the plan on how are you engaging schools and these are adolescents living with HIV in addressing the missed opportunities? Yes, just go ahead and answer as I get other questions.
Thank you so much for that question. So I maybe failed to mention, or I mentioned in passing, that we are intentionally also bringing on board what we are calling non-traditional key stakeholders in this agenda and in this dialogue. And we are bringing on board the Ministry of Education as well. So they are part of, they gave us a representative that is sitting with us even as we plan and move forward in this agenda of ending AIDS in children. And we are targeting to go into schools and talk to the teachers because they are part of the caregivers, especially for the children that go to school and are actually in boarding and are on care, so that they understand what it is or how to take care of the children that are on treatment, and also to help them with stigma reduction. Sometimes we find children that have been taken to school and have not yet been disclosed to, and so we are having a whole package for the teachers who we are also calling caregivers in schools, in terms of the care of these children, but also, you know, having programs where the adolescents themselves and the children themselves are going to be, you know, be called together, especially at facility level, where when they are on holiday, they are called together so that they are also talked to, encouraged, you know, like forming different support groups for them. We have facilities that already have those ongoing, but we are encouraging all counties, all facilities to have the same ongoing so that they can have these children coming over, especially when they are on holiday, so that they can have a support group even as they continue with their care and treatment. Thank you.
Thanks, Dr. Nelly. There's also a participant who's asked on what are our plans for sustainability. We know that Rapid Results Initiative is usually for 100 days. So maybe just take us through what the division is hoping that can sustain this momentum that we've kicked off very well.
Thank you for that question. So in terms of sustainability, as I was doing my presentation, I also mentioned that part of the agenda or the objective is to, strengthen what the mechanisms that we already have, for example, monitoring and evaluation, but also these strategies and interventions. We have, we've brought the counties on board, who are actually the owners of the process and where the real interventions are taking place, especially at the facility and community level. And we've asked them also to form task forces, but also to look into strengthening some of the mechanisms and the interventions that we have developed, and then also carry them through going forward. So and that's why we are saying we are not inventing anything new. We are not inventing the wheel. We are actually making use of the current systems that are already there, interventions that are already ongoing, networks that are already established, for us to just strengthen them and move them forward. So that way this is one of the ways we are ensuring that we are going to have sustainability of our gains after the RRI going forward. Thank you.
Okay, thank you. So I've noted the question on whether we plan consideration for use of long-acting CALHIV for improved adherence among young adolescents 10 to 14 years. So the country continuously updates our treatment guidelines, and this update one is guided by WHO guidance, but also by our team of local experts and researchers. We work closely with the HIV clinicians, Society of Kenya, and they do give us technical support, update us on research that is ongoing that will inform adoption of guidelines that are, especially treatment guidelines that are used regionally and globally. We also have to take into consideration the cost of treatment. So discussions with all the stakeholders, what does it take for us to start to change a regimen, various discussions on cost implications, on, of course, improving the quality of life, the drugs with better effects, minimal side effects. So those are all considerations that we take. And yes, we will discuss this once the opportunity to review the guidelines presents itself. Then there was a question on missed opportunities. I think, Dr. Nelly, you can make a comment. You did present that the data that you presented for the missed opportunities was up to March 2023. Maybe informing our audience the progress that has been made and how we are keeping track of these instances, like if it was a true missed opportunity and then it's corrected. So just give us a brief on that, Dr. Nelly.
Thank you, Dr. Caroline. So in terms of monitoring our progress of the missed opportunities, so we after we identified the missed opportunities, we also identified the facilities, as I mentioned, where these missed opportunities are. So the 1688 facilities, we have a list of which facility has how many missed opportunities in which indicator. And we shared this with the specific facilities, but also with the counties. And now we also give in the training of healthcare workers that I've mentioned, that is still ongoing, we are giving them tools for them to be able to verify that data. Because yes, we can say maybe from our end, we can see maybe Bahati Health Center has got 15 mothers that were not tested for HIV when they came to NC. So the facility needs to verify, is that true? Is those 15 that we have said we have identified, are they true missed opportunities, so that they account for every of those missed opportunities. So each missed opportunity is being accounted for at the facility level. So they'll tell us either this was a documentation error or this is a missed opportunity. Now, after they have given us they have verified the data and said, for example, out of the missed opportunities that were listed, these are the true missed opportunities. Then they go ahead and develop a line list of those missed opportunities, and then I'll go ahead and trace them and give them the service that client missed and document the same. And the M&E team has worked very hard and developed a dashboard that is very comprehensive, that is helping us to track progress. So for example, if it is Bahati Health Center, they had missed opportunities maybe for infant prophylaxis, say they were 7. And out of the 7, 2 were documentation errors, but 5 were true missed opportunities, and they were able to actually line list and trace them. As they are giving these children missed opportunities, they will be documenting this data, and we are able to see it in the dashboard real time. So it starts with the way the dashboard has been designed. It starts with orange bars, and as the missed opportunities are being addressed, the orange bar reduces and a green bar starts appearing on top. So the green bar shows the number of missed opportunities that are being addressed, and the orange bar will show the number of missed opportunities that are yet to be addressed. If they're at 60%, we'll be able to see that. If they're at 70% or 100%, we are able to see that real time. Thank you.
Thank you, Dr. Nelly. There's a question on the testing algorithm. Dr. Elvis, you can kindly take this up.
Yeah, sure, thanks. So I had mentioned in the opening remarks that we'll be transitioning to a 3-test strategy, and the 3-test strategy in test 1 is screen, and then 1 step, and then fast response. So we no longer have determine as 1. So I think that briefly answers that question. So we are working on a transition plan and an implementation plan, and we are going to be inviting stakeholders. We're going to do a lot of training and capacity building of healthcare workers and HTS providers. We expect to roll out this beginning January of next year. Thank you.
Thank you, Dr. Elvis, for that summary. Indeed, we just started work on this. The plan was also the 3-test strategy task force report findings were also launched by the Cabinet Secretary, and we are embarking on this plan to transition, as Dr. Elvis has said. So maybe Dr. Elvis, there's a question on how we plan to reach women in prisons with these interventions of ours.
Yeah, thanks. So of course, prisoners are a special population, a vulnerable population. We of course have linkage, of course, with these institutions. So I don't know how specific is the question, because we of course do this through our key population and special population program.
Yes, thank you, Dr. Elvis. Yes, there are indeed a specific program for these vulnerable populations where we ensure that our interventions reach those who are most in need. Now, there's one, yes, because, and we do acknowledge that they are affected and they are infected. Now, there was also a question. Dr. Nelly has talked about how we plan on monitoring the RRI results, and even going forward, there's a dashboard which we'll be referring to. For supplies, maybe Dr. Nelly, a comment on supplies. Like you'd mentioned that we've already pushed some supplies to the facilities that are participating in the RRI, because we've had challenges in the past of stockouts that have hampered some of the progress that we'd like to make in the country. So maybe a comment on that. I know you're not on the supply side, but we've been working closely with the HPT team. Thank you.
Thank you, Dr. Caroline. I wish the HPT team was here so that they answer that question comprehensively, but I will try my best. So for the RRI, we have commodities that came in just before, and that's why we were able to front load our facilities. And I know that it has been a challenge. The commodities have been part of the contributions or the contributor towards our missed opportunities, but we have been given assurance by the HPT team, and they are working round the clock to ensure that the commodities are available. So maybe I will also contact them. Maybe they can, give us, a more concrete response towards the same. But what I know is that they have given us an assurance that the commodities will be available, both the pharmaceuticals, but also the lab and diagnostics commodities as well. And the ministry or the country is committed towards this. Thank you.
Okay, thank you. Somebody has asked a question on how do we support disclosure when she's given an example of one spouse is infected and actually changes the medication of the child to a different, like she's got a paracetamol bottle. So when we have in our guidelines disclosure ranging all the way from how do we handle disclosure for children and also disclosure between partners. So once there's an SOP on if somebody is tested, they're supported to disclose to their significant other, either partner, also encouraged to bring children who are their children for testing as a way of identifying some of these missed opportunities that we're seeing for testing in our children because we are not trying to link, trying to do family testing. Like if we identify this household, a mother or a father has tested positive, can we make efforts to try and trace these children for testing? So, elaborate processes of counseling and support for disclosure and even linkages. We have a very strong network of peers stationed both at the facility. There are those also at the community that can support and walk the journey. We've had personal testimonies of peers going and supporting in the disclosure process. So having that, presenting such a case to the facility for linkage with the peer stationed at that facility or in the community, so that the person, the recipient of care is supported to disclose. And of course, this we know disclosure leads to better adherence. And as a country, this our clarion call, the U is equals to U, which means undetectable is equals to untransmissible. So with good adherence, you have undetectable viral load, you cannot transmit the virus. So U is equals to U. So having those messages continuously done and given to our recipients of care so that we can reduce stigma. A lot of fear of disclosure also has to do with stigma. So stigma reduction mechanisms, and the NASCO program working together with our stakeholders, with our communities, we're always consulting to see which innovative ways we can and how we can work together to improve adherence, enhance all these processes, and support our recipients of care. Yes, so now there's a question that has been asked about people living with HIV, access to medication for general ailments. I think that's also NCD. We are seeing an increasing burden of non-communicable diseases because we have a significant cohort of PLHIV that are living longer because of medicines working. So they're getting afflicted with non-communicable diseases. So we have engagements and we are doing advocacy that we have some of these medications covered. Okay, because yes, that is a barrier that has been identified, and we're working closely to ensure that they are able to access care for these other ailments when they need it. So this is a concerted effort between all stakeholders, and also having in place financing agreements and arrangements that will protect our recipients of care. Yes. All right. So let me check now on anybody who has raised their hand. Yes, the 3 participants. Bernard Mackenzie, please introduce yourself. Okay. Patrick Wambani. Oh, he's lowered his hand. Bernard Mackenzie.
Doc, I think it's only the panelists who actually have active audio.
Okay, seems probably there were hands. Okay, back to the chat box. So there's a question about plans for linkage to support groups that has been a challenge for quite a long period of time, and this affects the clients more so, CALHIV. Yes, this is ongoing. We work closely, as I've said, we work closely with the communities, our networks, and also our implementing partners to support these support groups. And having innovative, and indeed we hear testimonies of counties giving best practices. We have our regional groups where we have input, and we have best practice sharing forums where we have to come up with innovative ways of approaching adolescents and children living with HIV. Things like weekend clinics, having special camps during holidays. So all these are interventions that have been tried, and we've seen good results. We've seen improved adherence, we've seen improved viral suppression. So continuously supporting, so sustainability of this is also, some have even been taken up by the communities themselves, by the counties, because they're great initiatives and they have champions. And through this work, we see improved outcomes in this age population. Indeed, yes, the question on us seeing the burden of new infections amongst our adolescents and young persons. This is evident, and innovate. The task is upon us to come up with ways to innovatively preach prevention, and also adherence to treatment. As I've said, if you're undetectable, you're untransmissible. So that message needs to resonate with our adolescents and young people. So making these are all strategies that as a division, the approaches that we are using, being supported by our stakeholders and partners. Okay. I think we've addressed the question on community engagement based on this EMTCT framework. We've given our strategy for community engagement. Then a question on, are there any long-acting injectable ARVs approved for pediatrics? Currently, there are none. Yes, and those, I acknowledge all those who've congratulated us in the good work that we're doing, and for the presentation that we've heard from Dr. Nelly, and that the peer testimonials also work. We also have the Operation 000 amongst our adolescents and youth. They talk about just a message of support to have on adherence and viral suppression, which eliminates transmission. Okay. I think we should be done. We're done now. Would like to acknowledge those who've supported us in this journey, and we will be having planned topics that relate to this agenda of ending AIDS in children, and we hope that we'll continue participating and supporting the division's efforts, even at a clinical level. So having this child, preventing mother-to-child transmission, testing all mothers, putting all infants on prophylaxis, and indeed plan to manage those children and adolescents living with HIV, that they adhere to treatment and are not susceptible to advanced HIV disease, and hence end up succumbing to AIDS in children. So thank you to KNH, University of Nairobi, for this platform, and we will see you during the next session. So have a good afternoon. Thank you.
Thank you, Doc.